Welcome everybody. It's just an honor to be part of the summer school. I've been part before with different topics, especially talking about suicide prevention. Today we'll talk about something that is very, very different. So we're talking about the other flip of the coin, let's say, wellness. So my name is Eduardo Chachamovich. I'm a clinical psychiatrist with Miguel. I work at a different hospital here in Montreal called the Douglas, where we have a clinic that is in charge of planning and delivering psychiatric services for the Indigenous population of the north of Quebec. North of Quebec, there are two different populations. There are the Cree population, roughly about 19,000 people in 9 different communities. And then there's the Inuit population that lives a little bit further north, just below the Hudson Bay. There are 14 different communities and around 16 to 17,000 Inuit. So basically we have a small program that is a clinical program that is in charge of visiting every community, consulting patients, delivering training to the staff, assisting the policymakers when they need, and also developing training and support from all the staff, including family doctors, specialists, nurses, social workers, and as a second mandate, we also develop research in many different ways, usually based on the community's needs. So that's how research and clinical practice come together for me in the north of Quebec, but also we are involved in doing research in different areas of Canada, mainly in the Arctic, so Northwest Territories and Nunavut, and also international collaborations, especially with the Arctic, so Alaska and Norway and Finland and countries that also have indigenous populations living within the Arctic Circle. So just give you a very quick overview of what I planned for today. So I thought we would talk a little bit about the concept, the definition of well-being and quality of life, the history, health aspects versus the quality of life in general, and cultural aspects. And then I would like to talk a little bit about measurement. That's one of my passions. Cultural adaptation versus developmental measures, classical test theory versus modern approaches, things that we've been doing, are they adequate or not? If not, why? If yes, why? What is it that I think we should implement in terms of measurement to have a more sound and meaningful way of assessing quality of life, wellness, resilience, and those important constructs. And then, as just a quick example, I brought some of the data we collected and analyzed recently to show you how the classical test theory might seem to be appropriate, but sometimes is very misleading in ways we don't sometimes understand if we don't dig deep. So my aim with this is really to raise questions and open for debate so that we can be more critical of what we read in terms of cultural adaptation and validation of assessments. So the way I see wellness, it can be used in different areas, the measurement and the utilization of the concept, especially mainly started with research, and that's what we are doing here. It's a conference on research, but also for policy making, that's essential. And in the way that we can assess ongoing programs meaningfully. I'll talk a little bit about that later, but the concept or the increase in the use of quality of life and well-being as research topics happened after it started to be used more and more as an outcome in very different research approaches, and lately in RCTs, in randomized clinical trials. So it's not enough. Maybe if we go back 30 years ago, the classical outcomes would be morbidity and mortality, and that would be enough to show that one particular drug reduces either or both. Uh, but it's not more. It's not acceptable any longer to only have hard outcomes like those, and the patient-reported outcomes are increasingly more important. And among those, quality of life and well-being is probably one of the most widely used. So this is front and center in any intervention, implementation of any strategy. As you said, so you have to measure pre, post, and identify, first of all, if the strategy is working in terms of increasing well-being and quality of life. And secondly, if so, why? What factors are contributing to this? This is just like a backbone of the history of the concept of quality of life. It first appeared in the literature in the 50s, and that was the concept of happiness. So there's a famous book called The Pursuit of Happiness by Jones in 53, and that's where it all started. The positive psychology and the authors that started to move from researching health problems and the lack of happiness or sadness or depression or anxiety, towards also investigating what's working, why people are happy, or what make people happy. It was first used in a large survey in the 60s in the U.S., where there was one specific instrument for assessing happiness. And at that point, health was understood as being composed of two dimensions. So the negative dimension, that is the health problems and the suffering and physical or emotional limitations, but also a positive dimension, meaning that not only you're okay if you don't have problems, but you also have to have something. Like the absence of problems doesn't mean happiness or wellness. Before that, the only thing we had or used was social indicators that would be concrete numbers, like material well-being, so how many cars or bedrooms or TV sets or whatnot someone would have in the house, or life status or income. So those indicators would be used as a proxy measure for well-being or quality of life. But in 64, just like to, as a side comment, Lyndon Johnson used the word quality of life for the first time in one political speech in the US, saying that the ultimate goal of the politicians and the society as a whole is to increase community quality of life. That was used in a political context, but just following that, the World Health Organization published the famous definition of health, saying that health is not only the absence of physical or mental problems, but a complete status of wellness and happiness. And that then represented a big push for the positive psychology and different authors to start then developing measures of what happiness and well-being and quality of life would be. So in the 70s, we have the first instruments developed, like the sickness impact profile or the Nottingham Health Profile, and then finally in the 80s, the SF-36 that is the social function in 36 that was developed in the US and used like massively in every corner of the globe. Um, so those were like the starting points of what became a big movement uh, to develop more and more the quality of life and not only the conceptualization but also the assessment. And finally, as I mentioned before, the PROs or the patient-reported outcomes. That was when this concept took a different stage in terms of importance, especially when the FDA, the American Food and Drug Administration institution, that is basically the agency that regulates the new medications in the US, the approval of new medications, started to require patient-reported outcomes as part of every application for new patents. So that basically brought the quality of life and health-related quality of life to a different level, um, and that's what we see today. So that's just a quick illustration of what happened in terms of publication. That's a quick search on Medline from 75 onwards, using quality of life as a keyword. I stopped in 2005. There's much more from 2005 onward, so it's a very, very steep curve. Now there's a few journals that focus only on quality of life. And interestingly, quality of life became like a big umbrella for people who are interested in advancing measurements in psychiatry, psychology, and social sciences as a whole. So because it's a term that is very multidimensional, not tangible, and very, very challenging to understand and measure, it kind of brought together a lot of people who were working separately in those on those fields, and basically catalyzed the big movement of developing good quality assessment. And we'll talk about that later. Quick illustration of different terms that we find in the literature that somehow overlap but not entirely. So you can see, for example, economical status and environment, spirituality, and here I'm talking about quality of life in general and not only about indigenous quality of life. We'll get there in a minute. But so there's all those little circles that contribute to an extent to quality of life, but don't necessarily represent the whole phenomenon. And I would say the two most important circles would be health-related quality of life, or HRQL, that we have in red there, and then quality of life as representing well-being or happiness. So whenever you go to the literature, you see that there's a big split, and there's a reason for that. There's more than one, but so one reason is that health-related quality of life is a concept that came from medicine, and as such, the health component is very important. So as we saw, like the Nottingham sickness, the sickness profile, and the SF-36, they're all very health-centered. And the reason is that was the background that was used at the time. But there's another more subtle reason for that. One is basically it's kind of dominated by medicine and it's health-centered. The second one is because patient-reported outcomes are required, some authors would have, especially the pharmaceutical companies, would like to have PROs that are likely to respond to their interventions. So the more health-centered they are, the more likely it is that they will respond to medication or one health intervention. But if you start to include environment, culture, interpersonal relationships, and family, it becomes too broad for one intervention only. So it might be technically not as interesting. Yeah, in a way. The functionality aspect really came from one movement that tried to assess whatever health condition you have in terms of how, to what extent it impacts your functionality as a as an individual. So some scales would, for example, ask if you can climb stairs or walk 3 blocks or perform your daily activities as well as before you had the health condition. And that would be like a proxy measure to say, I don't I don't want to know only the severity of the condition you have, but I also want to understand to what extent it impacts your way to your ability to function or not. But unfortunately, the two are very connected. So you're basically assessing almost the same phenomenon from different perspectives. And quality of life is way more comprehensive than that. Uh, the way I see it, it's a personal view. When we're talking about wellness, resilience, and especially indigenous mental health and wellness, as we're going to see in a minute or two, um, we have to be comprehensive. I mean, whenever you try to be more restrictive, you're missing the point. Uh, that's why I don't think health-related quality of life would apply for indigenous contexts at all. Um, this is like a classical model of the interaction between different variables, so biological and physiological variables on your left, and then clinical symptomatology, environment here at the bottom, and individual characteristics like personality and motivation. They would all converge to general health perceptions and social and psychological support, uh, and then finally determining the quality of life. It's very well accepted. We're going to see that model a lot in the literature. There are some limitations to it, but I thought it was worth mentioning because this is something um, very widely used. It was published on the JAMA in '95, and it's still cited a lot. This is another classical model that is the Maslow pyramid, published in '54, which is also used again with some limitations. The one I like the most is the definition by the WHO group, that is the World Health Organization Quality of Life group. Um, so they basically say the quality of life is an individual's perception of their position in life in the context of the culture and the value systems in which they live, and in relation to their goals, expectations, standards, and concerns. Um, I decided to underline the perception and the culture for two different reasons. Uh, First, because it's a very subjective concept that really depends on how the person perceives the reality and the inner feelings. And secondly, because it's very dependent on culture. So one cannot just import a set of values to a different culture and think that they're going to work because it should be very culture specific. The properties of the construct would be, first of all, it's multidimensional, wellness slash quality of life. Um, as we saw before, there's different areas that will play an important role. It's subjective, so it depends a lot on the perception. It's self-assessed and it's time sensitive. So uh, same person under the same circumstances in two different points in time might have entirely different perceptions, and therefore this person's well-being or quality of life will be completely different. So we cannot assume that one set of circumstances will always determine one's level of quality of life, because it might not be true. That's why when we assess it, we need instruments that might be able to capture the wellness of this person at that specific time, and we'll come back to that later. Just to illustrate a bit the subjective angle of it, this is a very classic paper published in the late 90s that kind of pushed forward the disability paradox. This is like, so authors are reporting high quality of life in a population that was thought to have very low quality of life. That is, people with moderate to serious disabilities, and more than 50% of them report having excellent quality of life, which challenges the notion that we have about the perception. We ran a similar, smaller study with 90 people, elderly individuals who were being treated for cancer, for terminal cancer, inpatients at the hospital. And so we applied a set of questionnaires to see whether they would position their quality of life as low or high, and whether the mild symptoms of depression would play a role or not. And we found that 60% of those people placed their quality of life as being good or excellent, and levels of depression would be the most important variable to determine whether that person would be in a better or worse quality of life, regardless of the very difficult concrete situation. So the perception is very, very important. And that's why whenever we're going to talk about wellness or quality of life, we have to go back to the person we are talking to, and this is going to be the person to tell us how he or she perceives their situation. It's almost impossible for us to make assumptions. That's why it's so beautiful. When you go to the literature to see what's out there in terms of indigenous wellness, and there's a few interesting papers about that. There's important differences between what we call mainstream populations and indigenous populations. First of all, is the collective nature of the relationship. So there's a big difference in terms of where the emphasis is. In the South, the emphasis is much more individualistic. So the wellness is understood as the way I perceive my quality of life, whereas in indigenous communities, it's the community as a whole that makes that also plays a role. So even it's not conceivable that I would have a good quality of life if my family or my circle of friends don't. So the relationship is more important, whereas here it's a more individual assessment of your situation. There is the connection to the land, of course, which is in every paper you read and whenever you talk to anyone, probably one of the most important issues. We'll come to that again when we talk about assessments. So of course, if you use any of the instruments that are out there developed in the South, there's no instrument that's going to talk about connection to the land, for example. So even though all the items might perform well and the factorial analysis might be similar and all that, and we'll talk about that, I mean, it's missing the point. There's the spirituality component that sometimes is also present in the South, but in a different way. So spirituality here is more connected to the way that this person relates to a set of beliefs or God or the religion, whereas what the literature brings in terms of indigenous communities is spirituality being also linked to this higher power, but also it also relates to the continuity of generations and the history that is behind that individual. So it has also to do with the tradition and the continuity of the people as a whole. And fourth is family and communication. So again, the network and the relationships as being placed of one of the most important aspects. And finally, traditional knowledge. So the transmission of the traditional knowledge, to what extent this person acquired enough, or is in contact with the elders enough, or feels that that he or she will be able to transmit that to the future generation, so that they're part of the chain of acquiring and transmitting the traditional ways of living, is also very, very important. But we know all that. The literature is very clear in pointing out all those factors, but unfortunately, most of the papers that are available or reports on wellness, on indigenous wellness, rely heavily on concrete indicators, especially the community indexes, such as housing and income and food security, but very, very few of them would take into consideration all those aspects, for example. So if we move a little bit and go and talk about measurement, this is one quote that I like. Life is complicated, and there's no reason why one should not invest as much into properly assessing quality of life as into brain imaging, for example. Quality of life is a very difficult concept to work with. It's very comprehensive, it's very sensitive, it's influenced by a lot of different factors, and it varies from culture to culture, whereas brain imaging doesn't. But it's not an excuse not to dig deep. It's just a motivation to go deeper, and it's completely feasible and doable. It takes a lot of time. It takes a lot of interaction with the people you're working with, but it's a very interesting exercise. So measurement. That's like another very famous quotation by Stevens in 46, and it still applies, is consists of rules for assigning numbers to attributes to objects based upon rules. So basically, he was the first person to try to develop a way to measure anything, and he started with physics and then evolved to psychology. This is the guy who first developed what we call the different variables, the different categories of variables, which are nominal, ordinal, interval, and ratio. Nominal is, for example, names. So a variable that is nominal could be, for example, the name of the person you're interviewing, and they're all on the same level. There's no hierarchy. Like a name is a name. There's no name that is greater than another name. It's not a ruler, it's just a level. Ordinal is when you start to have an order. And the way Stevens described ordinal variables was by placing rocks according to how hard they are. So you would have like soft rocks on one extreme, very hard rocks on the other extreme, and then you would place them according to hardness, and you would determine by hitting one to another, and then the one that was harder would stand and the other one would break, and then you would know, well, this goes here, the other one goes here. So in the end of the day, you have like, let's say, 10 different rocks, and you know that they go from the most soft to the most hard. But that's all it is. A sequence of of rocks, and you know there's an order, but you don't know the, how much more hard this stone is as compared to the previous one, for example. You only know it's harder, but you don't know how much more. The interval is what we know, for example, for height, where you have like the centimeters. You know that there's 1, 2, 3, 4, 5, and always the difference between 1 and 2, and 2 and 3, and 3 and 4 is constant. So you not only you have order, but you also know that the intervals are always constant, so that you can say that, for example, a page that is 10 centimeters long is twice as long as one that is 5, because the intervals are constant. And ratio is something that we don't find very often. Is, for example, the temperature in Kelvin, where you have an absolute zero, where the zero means something. And in psychology or psychiatry or social sciences, we don't have an absolute zero, so we can forget about that. Those two books are highly recommendable for anyone who wants to study the basics of measurement. It's like very, very interesting. They're conceptual and theoretical, more so than practical. But this guy, I mean, he digs deep to understand what's behind measurement. So it's not only a bunch of numbers, but what is the science of measuring about. And he says that the numerical estimation and expression of the magnitude of one quantity is relative to another. So that's what I'm talking about when I say the centimeters. I mean, you have to be able to compare one to another in terms of how great the differences are. When I was mentioning the example of the rocks, you only know that one is harder than another, but you don't know the difference. There's no magnitude there. Right, yeah, that's a good example, like a Likert type scale.
Mm-hmm.
Yeah, so you know that very bad is worse than bad, and bad is worse than neutral, but you don't have any idea if the difference between neutral and bad is the same as between bad and very bad. It's greater. It's you don't know. Why is it important? Because that's the basics of measurement, and this is just an illustration of what an ordinal scale is. That's the top of the ruler, and what an interval scale is. That's the bottom. So on the top, we know that 1 is greater than 0, and 2 is greater than 1, and 3 is greater than 2, and so on. But as we see, the differences are variable. So we just don't know. I mean, if I told you, is 8 2 times 4, you might say yes or no. You have no idea. Is 4 2 times 2? You don't know. Because you could have like 0, 1, 2, 3, and then 4. So 4 would be like 5 times 2, for example. When you have an interval scale, as we have on the bottom, then you can certainly say that 2 is 2 times 4, and 8 is 2 times 4, and so on. Why is it important? Because, and I like to make this point, ordinal scales of measurement do not support mathematical operations needed to calculate means and standard deviations. So basically, ordinal scales don't support parametric analysis because they're not numbers. When you say 1, 2, 3, 4 in an ordinal scale, you could well say A, B, C, D, or I don't know, alpha, beta, or whatever. They're only symbols that represent an order. But they're not real numbers. They're only real numbers when you know that you have an interval scale where 1 and 2 and 3 and 4 and the differences are constant. This is the basis of what we call modern psychometrics, and this is one of the most common mistakes we find in literature, in social sciences and mental health, because nobody gives a damn if we can or cannot use ordinal scales to apply parametric tests. People just 99.9% of the scales we use in our field are ordinal, and therefore we should not use any parametric test. But as you see in the peer-reviewed articles, most people do. You only check the normality and see if the QQ plots or the PP plots seem okay, and then you go on and use parametric, assuming that there's a normal distribution, but it's not enough. I'll show you later why this is important in a context like ours. I just, for now, want to make the point. So what is it that we see in terms of measurement in the classical test theory? Usually it would be reliability, which means, is the test able to give you the same measurement over and over? Which is of course important, because you need to have a measurement that is reliable, in the sense that if you use it 3, 4, 5 times, you get similar results. It has to be valid. So is it measuring what its intent is? So if I want to measure quality of life, is it capturing quality of life, or maybe capturing something else like depression or low functionality or something else? But the way that it's usually done is through factorial analysis, so exploratory factor analysis and confirmatory factor analysis, in a way to show that, for example, that scale is has the same grouping of items if I use in Europe or in Montreal, and then in Nunavik with an Inuit population. That's what the literature usually does. It's a very well-known approach. It's been used for 70 years, maybe more. But there are some very important limitations. And the most important limitation is we can show that the scale or the instrument behaves as expected, but we cannot show if it behaves accordingly to the new reality we want to assess. So we're basically trying to show that it replicates the same psychometric performance as compared to the population it was developed for. But it's not enough. I don't know if it's capturing what it should. I don't know if the phenomenon is similar in that indigenous population I'm working with as compared to the population it was developed for. And I kind of know it's not. And finally, I mean, the way it's as if you have a flashlight. So you use the flashlight here, and you have only a circle of light where you can then see what's there. You don't see what's in the dark. You bring the same flashlight to a different cultural context, and you turn it on, and you see the exact same things. And then you think, wow, so things are similar. But basically what you're doing is you're only looking to the factors that you know exist. But everything that is outside your scope of knowledge is not being taken into account. So, and maybe that's what's most important for that cultural setting. So just showing that the instrument or the measurement works as well as is not enough. It's very restrictive, very limiting. And plus, the classical approaches sometimes don't show that. We think they show, but they don't. One of the most important limitations is the CCT approaches don't deliver interval measurement. The items are not assessed properly. It does not assess for diff, which stands for differential item functioning. I'll come back to that, and I want to show you an example that I find very interesting about that. And therefore, there's limited generalizability. I mean, we think that by using the same scale, you're increasing the possibility to compare that population to the rest of the literature. We are not. We're measuring different things and comparing apples and oranges. And the cultural adaptation is therefore very limited. We're not adapting to the culture, we're basically replicating similar structures. One way of getting around that is using modern psychometric approaches. There's different approaches. There's the item response theory group of approaches. One of them is Rasch Analysis. It's the one I feel most comfortable working with. And basically what it says is that the result of the encounter of one individual and one item is the result of this person's ability and the item difficulty. So if we think, for example, wellness, and if we have one item or one scale that is there to measure wellness, it should measure wellness and wellness only. Anything else that might influence the performance of the item is noise, and is there just to confound the results. It might sound a little difficult to grasp, but the idea is that that scale has to assess wellness, for example. And I don't care. I mean, if wellness is seen differently in Montreal and in Bouvirnituk, that is one Inuit community in the north, then instruments should be different. They're not supposed to be the same. They should measure the same thing, the same feeling. But if the concept is different, if the determinants are different, and if the understanding is different, then the items and the scales should be different. And if they're well developed, you're going to be measuring the same feeling, then the results are comparable. It's not only because I'm using the same scale here and there that the results might be put together. I mean, it doesn't mean anything. It's easier for us as researchers because we think, well, we have the scale already, we're just back translating, and then checking the semantic equivalence, and then therefore we have two different results that we can say this is better than this or this is greater than this, but it's misleading actually. What we want is to capture that construct, that trait. And if we need a different set of items, so we'll have a different set of items, and then we have meaningful comparisons. One of the advantages of the modern approaches is, for example, to check the response, the Likert type response categories. This is another thing that is frequently just imported. We get like the five response categories from here, like very bad, as you say, very bad, bad, neutral, good, and very good, and then we bring it to whatever. Is it perceived the same way? My guess is it's not. That's an example of one paper we published a few years ago, checking the performance of one quality of life scale with illiterate people, and compare that to university degree holders. It's just the standard scale that we always use, but we had the feeling just by interacting to people that the subsample of illiterate, and we wanted to have a very diverse population because we wanted the results to be representative, so we made sure that we had illiterate people with low level education and higher level education represented in the sample. That was a big sample, like 14,000 people. So we had the feeling that people with lower education, the 5-point Likert scale was very. I mean, they didn't really use the 2 and the 4. There was like 0. It was like bad, good, or neutral, and the 2 in between were not used. So we decided to run a Rasch analysis on that, and we saw that the items didn't perform well because, as we see at the bottom, here we have like 5 different curves that should represent the 5 points. And what we want to see is that 0 comes first, and then 1, and then 2, and then 3, and then 4. So that people are using the 5 points. As we can see down here, the green line is basically not used because it never goes above the others. So it's noise. It's not doing anything. It's only decreasing the quality of the responses. When we regroup the 5 points into 3, the performance of the scale and the results were much better. So can we assume that just because we developed the scale with 5 points or 7 or 3 or 10 or God knows how many, that it applies to a different culture? No, we have to check it. Maybe it doesn't. Maybe it's disturbing more so than informative, for example. So that's one other comment I would like to make. This is the paper, and that's how we can see at the top 3 items, 3, 4, and 15 were not performing well. That's why we don't have the colors there. So we then regroup them into 3, and then we can see at the bottom that the orders of the responses are all as expected. As a result, all the scores of the scale are much more interesting, much more reliable, I would say. The last comment I want to make before we can open for more questions is the differential item functioning. And I think this is a great thing that people don't comment about, and that's a great way to show how high quality scientific validations should be done. And this is so the concept, so that you know, is we are getting here 2 different people with, let's say here we are measuring wellness. So let's say we have 2 different people with the exact same level of wellness, like just the same. And then we have one item that says, how well do you feel today, for example. And then we apply that item to 2 different people with the exact same level of wellness. If the item is performing well, if it's measuring wellness and wellness only, it should give us the same result. I don't care if one is black, one is white, one is depressed, the other one is not, it doesn't matter, because the item is there to measure wellness and wellness only. If the gender makes a difference on how the person is going to respond to that item, so the item is not measuring what it should measure. If the color of the person, or if the background, or whatnot, if there's any interference, then the item is not good. Does the classical test theory address this? Not at all. As an example, we got the K6, the Kessler 6-item scale. That is a scale that is a short version of the K10, was developed by Kessler to be used in large surveys in the US to measure the level of psychological distress. And so we have two different samples. One sample is 2,500 plus Inuit respondents that were interviewed during the Inuit Health Survey. That was a very big project that was carried out in all regions of Canada where Inuit live. And then 33,000 American subjects that we got the data set from a big American survey. Both use the same instrument, K6. The K6 has been already validated for indigenous populations in the literature in the US. There's a few papers showing that the factorial structure is similar when it's analyzed through classical test theory. So what we did is we compared the performance between across the two groups, and we wanted to see what would come out of it. So we used both CCT, so classical test theory, and Rasch Analysis, starting with classical test theory first. So we split the sample in two, 50% randomly, 50% of the Inuit and American in one sample, and the rest, the other 50%, as a subsample. The idea was to run exploratory analysis with the first sample and then confirmatory analysis with the second sample. You don't want to do both with the same sample because you're basically bringing bias to your assessments. Both have the same factor solution, so one factor only. They look perfectly comparable, very similar. We ran a Monte Carlo analysis to confirm that the finding was not by chance. It wasn't. The reliability, as based by the alpha Cronbach, was very good, and again similar, 0.85 against 0.86. In a way, it's expected that the US, the reliability is higher because the sample size is also higher. And then we ran a confirmatory factor analysis with the other 50%. That's the picture, that's the output from the software that runs it. Here we have the indexes, they're all very acceptable. Maybe RMC not as much, but again, 0.76, 0.76. So if we stopped here, we would say K6 seems to be well accepted and valid for Inuit population. Therefore, the results are reliable and comparable. Then we went on and we ran the diff analysis for three different aspects. We ran the differential item functioning for gender, for age, and for community. Community meaning Inuit versus mainstream US. And once again, the instrument was developed for mainstream US population. Gender-wise, perfect, no problems there. Age-wise, no problems there. And then when we check the groups, so the cultural backgrounds, what we found is that, and this is just an illustration, we had that for 3 out of the 6 items. For the same level of psychological distress, American people would endorse items more easily than Inuit people. So Inuit would require a higher level of psychological distress to say, for example, bad to one item, while the American population would say bad at a lower level of distress. Why is it important? It's important because the score you get from the scale, even though, let's say, you might get a 15 out of 30 in the American population and 15 out of 30 in the Inuit population, and it would say the level of distress is similar. It's not. The scores are similar, but they don't reflect the same level of psychological distress because the items are not well developed to capture the reality of, in this case, the Inuit population. So there's more specificities that are playing a role in the Inuit subgroup that are not in the American subgroup. And it's very fine-tuning. But that's what we have to pay attention to. That's what makes the difference, because if we don't check that, we don't know. I mean, you just use the scores and assume that they are comparable. And then someone will say, well, we're using the same scale. It has the same factorial structure. It was confirmed. It's reliable. So why not? Well, that's the reason, because the items are not assessing what they should be. That's a good question. Like the ideal number is usually around 200, 250. You don't want to go to this. This is statistics. They rely on chi-squares. of different points. When you have too big of a sample size, you have the problem of very small differences that are not meaningful. They become statistically different. So it's a reverse problem in a way. When the sample size is too big, every little difference that might not be important become significant. Usually what we do in cases like this is you break the sample in 3 or 4, and then you try to run the analysis in one sample and replicate in 2 or 3 smaller samples. Because I mean, if you have like 33,000 sample, everything's going to be significant. Even when it's if it's small, it depends on how many items you're dealing with. It depends on, it has to be unidimensional. So there's some other things that we can also check before, but we can run diff analysis with sometimes 80, 70. It's possible. Too big sample sizes are the problem. It's too small. Then we have to see. Another important thing of the Rasch analysis is that it's not sample oriented. So the notion that you need a very big sample size to be representative doesn't apply here, because if you have a set of items that are clean and performing well, then it doesn't need to be validated by a big sample. Now, what I can say here is that I'm not sure which is measuring which, and it might be measuring psychological distress and something else. There's another thing that is not only psychological distress that is playing a role in the difference. Which is the correct one here, I don't know. Maybe it might be the American sample that is not well calibrated, for example. I'm not sure, but what I can say is that if you get the results from the American population, if you add the items of the K6, and then you get the results from the Inuit population, and you compare, then you're comparing orange and apples. You can't do that. Which one is the correct one? I don't know. Before maybe trying to refine the measure, and maybe you have to analyze it deeper to see. Yeah, you're right. So yeah, this is one item only. We do that for every item.
Right.
And they behave similarly. That's expected. So the person location means the level of psychological distress. So it's
Okay.
expected that as you move from left to right, and the level increases, chances of this individual endorsing the item are higher. The more distressed the person is, the more likely she is to say, yes, I'm distressed, of course. And the pattern here is similar. The difference is the difference between the blue and the red that is telling in a way, because the point, let's say for two people who have the level of psychological distress at -1, you would expect the item to be just one above the other. If they're not, that's where the difference, that's where you need to be more in distress to have the same chance of endorsing that item as compared to an American. And this is what's going to bring bias to the final result. It's not the total. It's not when you add everything, but it's a Rasch derived ruler where you have the ability. So in this case, the level of psychological distress. It's not just by summing all the items as we would do in the classical test theory,
Right.
but it's that represent the level of psychological distress. That's it. That's it. So I think this is something we should do every time we assess the performance of any given instrument in a different culture, for example, because we just don't know. If we don't do that, you don't know. So that's just to summarize. The usual practice of 80 to 90% of the publications we see when we do the cultural adaptation is basically doing the translation, the back translation, focus groups to check whether the wording is correct and the content is correct, and then sometimes pilot data, and then we analyze with classic test theory whether the reliability and validity are there or not. I think this is important. I don't want to say that we should forget that and just disregard this. My point is that it's not enough. There's a whole bunch of different cultural expressions and values that are not taken into account, and also the measures have to be assessed in more depth so that we know whether the items perform well and the scores are truly comparable. And then we can use that to measure pre-post interventions or compare two different populations or have baseline data on correlations and all that. Because after doing that, then we have a meaningful tool. That's again a compilation of the literature on the best practice for measurement. So one is the development of specific instruments with common underlying trait. So again, if you want to measure wellness, it's more important that that instrument is well targeted for the Inuit population or the Cree population, and not only a mere adaptation of what we have in the South. If the two instruments are well developed and well calibrated, they might have complete different items. They might talk about complete different subjects, and yet the scores are comparable because their scores are wellness. And if wellness is very different from what I understand to what another person understands, so probably the items should be also very different. Or also alternatively, they could, and that's what it usually looks like. You have a set of common items, and then specific items for different populations according to the cultural context. It has to be based on intense discussions on the conceptualization, the factors, and the response scale with the stakeholders in the community. Ideally, you would like to have pilot study with preliminary psychometric analysis and then a field work where you're going to test the final version and then show if there's diff, if there's no diff, if there's diff, how to approach it, and so on and so forth. So the questions that I would like to touch upon, and I think maybe did, is how generalizable the results are or are not. Is it too time consuming? Some people would say, so every time I want to research on wellness in a different community, so I have to do all the work again? Well, only if you want to have meaningful results. If you don't care, then maybe not. But yes, you do. It's a very interesting exercise, though. It's not a waste of time. This is how you build knowledge. This is how you build alliance. This is how you build commitment between the researchers and the community. This is how you engage the communities. And it's time consuming and it's money consuming, and it is. But that's really important. That goes back to the famous quote, like garbage in, garbage out. So if you don't have good measurements that are well developed, it's garbage in, and whatever results you have will be garbage out. So yeah, it's cost effective, definitely so. Is it feasible when you have tight deadlines? That's a challenge. That is a challenge. That's like the encounter between the research world and the communities. That's a very hard topic to navigate, but we have to have time and we have to do it. Maybe if the deadlines are too tight, that's not a good moment to do it. You want to do it in a different moment. This is time consuming, but it's very, very telling. So that's how I see it, at least. So we should have some minutes for questions. But let's say if you have one instrument that was developed bottom up, as you were saying, and properly, why would you need another one? That's a good example where you would probably be you would find noise when you measure, and you wouldn't know where it comes from, because it wouldn't be in your instrument that factor wasn't in, but it was definitely playing a role on how people would respond to it. So that's but just to go back to your first question, one thing I didn't mention when we ran the K6 study, this analysis, is that we didn't find diff within populations. So we just submitted that for publication. It's not published yet, but one of the arguments I make is you can use for pre-post within population, because there's no diff for gender or for age, for example, and it performs well. You should not do it across populations. So that's one approach. Yeah, you could have more than one instrument, for example, if you want. And that's what we usually do, right? Because there's no one instrument that covers everything. So you would have two or three that are specific for different constructs, and then you would see the difference in two or three different assessments. You might need to revisit your instrument after a while, and it's totally acceptable. It's very interesting, actually, because maybe there's a new factor, especially in communities where there's rapid change. So I assume that in Inuit communities in the north of Quebec, if you go back in 5 or 10 years, probably there's a different thing that is not there right now. You can try to run diff analysis and see what happens. You have to split the sample according to factors, so it could be gender or something else, or anything that is driven by theory. You might just think that there might be a diff there because of a theoretical aspect, and then split. It's doable, but if you have completely different results from two researchers, and that's what I saw, and I still see a lot in Inuit communities, is that the scales are not, they don't perform properly. They're very, they're not understood as we think they are. it might, and it might also speak of the need to couple qualitative approach and measurement development. Usually, the qualitative approach is always the first step. You never start something without going deep uh, with a qualitative approach. Could be focus groups or one-on-one, and then you build from there. If you do the other way around, it's not going to work. You don't necessarily have to. If they all come together as one construct that is well-being, for example, then you would like your scale to capture all those. Sometimes you don't need too many items. If the items perform well and if they're well calibrated, you need maybe 4 or 5 for each component, and then it should be enough.